non-ischemic imaging is even more important because it starts with diagnosis. Which non-ischemic cardiomyopathy? There are dozens of these, and imaging can provide an accurate diagnosis. For instance, this is probably not related to catheter ablation, but when you have a diagnosis of cardiac sarcoid with edema and inflammation, maybe catheter ablation is not the good way to go, and you should rather use drugs. So there's a huge impact of imaging on describing what's the cause. And then once the cause has been identified, there's also a huge impact of imaging to describe what's the distribution of these scars, because it's much less stereotyped than in infarcts, and because it's very often undetectable with any catheters, because these scars can be located in the intramural layers of the myocardium. There's no way any catheter can see that, or subepicardially located close to the LV summits. And even if you're mapping from the epicardium, you won't see that because the thickness of the fat in the epicardial space is too high for you to be able to detect any abnormalities there. So it's really finding hidden substrate, and then obviously going faster there and applying the appropriate route to get there. That's important. And potentially sometimes also deciding on what's the optimal energy to reach it. This is a huge impact of imaging. So I don't know if you agree, Pierre, but I think there's a huge impact on efficiency as always, because you go to the right spot faster. But also I'm expecting, but this is very complicated because performing randomized controlled trials on non-ischemics, first, they are more rare than ischemics. Yeah. Plus, it's so heterogeneous that it's impossible to match. But anyway, it's obvious that you see the target, and so you're probably more prone to reach it when you see it.
Absolutely.
So you think, yeah?
Oh, absolutely. The worst case scenario here in non-ischemic is when you have no imaging to guide you, because there are not infrequent situations where the patient is having VT, may receive shocks, and you have no idea of what the substrate is, because you don't really map it with catheters, and you may not be able to induce the VT, or it may not be tolerated, and you have no clues. So you can use the 12-lead morphology and try to do some pace mapping to reproduce that. It's quite limited in those patients in whom you cannot map the VT properly. Then imaging becomes absolutely critical. And as you said, Hubert, it even allows you to decide whether you're going to go epicardial or not, and you know that in advance. You can refine your strategy, and so it's really a game changer here.
I think it's important to understand how or the broad spectrum of options that you guys have to access the substrate. You can go from the RV endocardium, so the right side of the septum, the LV endocardium, but you can also go from the CS, and sometimes you can even go via perforating branches of the CS in the septum when it's deep substrates. Some are also doing ethanol infusion, either in the veins or in the arteries, and all that imaging can show you. We can map where the arteries are. We can map where the CS branches are. We can analyze how deep is the substrate. For instance, this case, Pierre, can you tell this story?
Yeah, I was very impressed with this patient. He is almost 80 years old, known for a non-ischemic cardiomyopathy. He's been implanted with an ICD. You can see the artifact on the CT images here. And he was flying back from the French Antilles and started to receive ICD shocks while flying. So there was a bit of emotion in the plane, of course, you can imagine. And so they landed in Paris, and then he went to a reanimation area in Paris, and they had to put it until under general anesthesia, intubated, ventilated, because there was no way they could control the arrhythmic storm. And so he finally was transferred to us in Bordeaux. So he was still intubated, ventilated at the time. So we did some imaging. Of course, he was having an ICD. Not to say that MRI is not possible in patients with ICD. It is possible. It's not a safety concern. It's a quality of image concern. So those ICD, they are MRI proof, but they kill basically the images. And so we did some late enhanced CT, which is similar to the light guide for the MRI, same concept. And it shows what is considered by EP doctors as a nightmare, a very large.
Maybe I can comment on this image a bit.
Yes,
So what you see on the what you see on the left is the arterial enhanced CT. So it's the same thing as a coronary CTA. So it's when you inject the contrast, the first pass of the iodine through the heart gives you this image. So this is a fantastic image to map the anatomy, measure the thickness of the ventricular wall. We saw that in ischemics, but also map the arteries and stuff. You can also map fat, particularly in the right ventricle for ARVC. So it's a very interesting method, not only for anatomy, but also for certain substrates. But for fibrotic scars that are located in areas that are in areas of preserved thickness, you don't see that on arterial enhanced CT. For that, you need late enhanced CT, which is the similar thing as late enhanced MR, except that it's done with iodine and not with gadolinium, and that it's a bit more noisy. It's better spatial resolution, but a bit more noisy. Of course, if you don't have an ICD, it's better to do that on MR. You have a better contrast, but still you can see that. And this patient, in fact, we managed to get his old MR performed 10 years before, prior to ICD implant. And you see that the substrate didn't move much. It's almost transmural there, but in other areas, it's intramural, maybe 2 millimeters depth, and the thickness here is probably greater than 1 centimeter. So there's no way you can achieve transmural ablation with RF from either side of the septum here. Maybe here, but here or there, it's impossible. Yeah, so Pierre, how did you manage the patient? This is
maybe you just get back a second on the previous slide, because again, this is really a nightmare. You know that if you ablate from one side, then the blood pool on the other side will act as a heat sink, and you will never be transmural. And it works, it's symmetrical, of course. So these septal VTs are really complicated to deal with, particularly if you have a big substrate, and here it's huge. So I really was anxious, and when I saw the images, and you can move to the other one, really, so see how big this is. We made the decision to straight go for bipolar ablation. So we've been using for this case a Carto system with some smart touch ablation catheters. You can see the contact force, 6 grams on the right side. And I think it was the way to go. Again, the patient was dying from storm. He was intubated, ventilated, quite dramatic context, and pretty old, some kidney failure, etc. It was really a difficult situation, and I wanted to giving the highest chance of success for a single procedure if possible. And we did the ablation with 2 catheters, one in the RV, one in the LV. You see on the right part of the slide, it's just showing the scar area, which is massive in septum, and we took the decision to create 2 ablation lines that would transect the scar. We had no idea really where the arrhythmia were coming from, because it was several monomorphic morphologies. We even had some polymorphic VT in this patient that were recorded. And you see the X-rays on the superior part showing you the two catheters, the two ablation catheters. This is not visible in the CARTO system. You have to have a dedicated research toolkit that we don't have access to see the two catheters in 3D navigated. So we just saw the LV catheter. We choose to monitor the LV catheter, and we placed the RV catheter facing it, with multiple angle fluoroscopy. You can do a good job at making sure that they are really close each other. And there has been very clear demonstration that this type of bipolar ablation is way superior to unipolar, sequential unipolar or synchronous unipolar deliveries. So I think Hubert mentioned that the wall
superior in terms of damage, right?
Yeah, exactly. Yeah.
Yeah,
well,
it's a relative judgment.
Yeah,
here you needed something very powerful.
Yeah, that's very sad. It's the only way we have to treat patients. It would be much better to restore function, but we're not there yet. So yeah, we thought that we would be more effective with ablation by choosing bipolar, including in those areas where, well, this patient has a preserved wall thickness, meaning a centimeter to target, which is out of reach for the conventional RF. And there were some basal areas in the septum that were even superior to 1 centimeter. So really, thanks to imaging, we knew that it probably was the only way. And I was very impressed by this patient because it's been 6 months now, and he had zero arrhythmia in the logs of his device since the ablation. So it's a great success, which I feel I should attribute to Hubert and images, because it was a game changer for this patient.
You mean to inHEART?
Yeah. Thanks.